Hello, and thank you for joining this targeted oncology presentation titled The Evolving Role of BTK Inhibitors in Treating Chronic Lymphocytic Leukemia. Treatment for chronic lymphocytic leukemia has evolved in recent years from standard chemoimmunotherapy approaches to strategies based on novel targeted agents. Today, we're going to talk about the evolution of routine tyrosine kinase inhibitors, which are now central to the treatment of CLL. I'm Dr. Ian Flinn, Director of the Lymphoma Research Program at the Sarah Cannon Research Institute in Nashville, Tennessee. Today, joining me is Dr. Jan Berger, Professor in the Department of Leukemia, Division of Cancer Medicine, the University of Texas MD Anderson Cancer Center in Houston, Texas. Thanks so much for joining us. Let's begin. Jan, let's start with some basic biology and rationale for BTK inhibition in treating B-cell lymphomas. Can you walk us through some of the logic there?
Yeah, thanks, Ian, for the introduction. I think one of the fundamental questions is, what is BTK? Why is it emerging as such a successful therapeutic target for CLL patients? So BTK, or Bruton's tyrosine kinase, is a kinase in the cells of CLL cells, which is very essential for transmitting signals from the surface of CLL cells into the cell. And its main role is related to the B-cell receptor, which is a key molecule on B lymphocytes and also on CLL cells. So I think that's been one of the major discoveries of the last 1 or 2 decades, that the B-cell receptor is so important for CLL biology. When that gets activated, then it transmits signals which the CLL cells need for growth and which they need for survival. And this signal goes into the cells with the help of these enzymes called kinases, and BTK is one of the key kinases. If you don't have a functional BTK kinase, which actually can happen in patients who have a very rare immunodeficiency called XLA. Those patients have mutations in BTK and they can't make any functional B lymphocytes. So it is very important for the growth, for the survival of B cells, normal B cells, and what is interesting for the CLL side of things is that if you block it in patients with CLL, then you induce patients to go into remission. So it has emerged during the last decade, I would say, as the most successful therapeutic target. It is expressed in normal and malignant B cells. And if you do like a hierarchy in terms of efficacy, in which diseases is it very effective, then I think number 1 would be chronic lymphocytic leukemia, where we get very durable remissions and the vast majority, almost all patients, respond, but it's also active in other B-cell malignancies. And maybe you want to comment on which other diseases it's effective, where is it approved, and do you have like an idea why is it so successful in CLL and why is it maybe not as active in other diseases like DLBCL?
Yeah, I mean, you brought up a number of interesting things to talk about. I mean, first of all, that you talked about X-linked agammaglobulinemia, XLA, and taking a disease and learning from the biology of that and turning on its head and making a therapy for these B-cell malignancies, I think was really fascinating and really tremendous early work in this field. But prior to this, to BTK inhibition, certainly in many diseases, for instance, chronic lymphocytic leukemia, we were talking about chemoimmunotherapy and all the off-target toxicities that you would get, the collateral damage from the chemotherapy that surrounds it, and that's true beyond just CLL. That's true in mantle cell lymphoma and other diseases. But now we have several different BTK inhibitors that are approved for the treatment of chronic lymphocytic leukemia. We have multiple ones that are now approved by the FDA for the treatment of mantle cell lymphoma, but we also have 2 that are treated for that are approved for chronic lymphocytic leukemia, acalabrutinib and ibrutinib. And so that's really these drugs have changed the treatment paradigms completely for many different B-cell malignancies, including diseases like Waldenström's macroglobulinemia. So those paradigms have changed dramatically.